when I'm seeing patients with diabetes in the clinic, I oftentimes in the back of my mind am thinking of diabetes distress. And is the person sitting in front of me experiencing diabetes distress? I look to see, are they taking their diabetes medications? And if not, is that they're feeling burned out from diabetes, that they're tired of having diabetes, the burden of living with diabetes day in and day out, it's just become too much for that person with diabetes. So I listen in the words they're saying, as well as asking questions about diabetes distress, because it is very prevalent.
Diabetes distress is quite common. There are some validated tools that are options to give people, but I think just asking how a person feels about their diabetes, what's important for them. But I think with diabetes, there's just so much being asked of people in terms of monitoring glucose levels, making tons of lifestyle changes, monitoring food, monitoring, being mindful of physical activity. And then if a person's taking meds that can cause, glucose to go too low, worrying about low blood sugars. So it really is a lot. And so it's very common for people over their lifespan to experience different times of diabetes distress. It is really something we should be assessing for at each visit, because you could have the best treatment plan in the world, but if someone's experiencing significant diabetes distress, it's going to be really hard for that person to follow the treatment plan, for them to take the medications as directed.
And we really try to emphasize, especially with our medical assistants who have a huge role in our model, is that, a lot of times we as a healthcare system tend to be focused on depression and specifically using tools like PHQ-9. And that's great, it's super important. But diabetes distress is much different. And sometimes the things that are within the PHQ-9 can overlap, but really it's those subtle hints that lead to those really meaningful conversations that can give you a great appreciation and better understanding of the distress they're dealing with day to day.
I think making sure that we're listening. We always try to listen to our patients as best we can. That allows you to pick up on some of those cues about things like really thinking through social determinants of health, like what is the housing situation, what is the food situation. All of those things are going to add to a high level of distress, and then you put on this chronic disease on top of it. So really trying to use our resources. I think
overcoming that first barrier when they first come into the pharmacy and they're like, hey, I just got diagnosed with diabetes. What am I doing? What are these meds? And kind of taking care of the patient as a whole. And yes, giving them proper counseling on their medicines, but also, connecting them to other care that they may need to.
I highly recommend, working with your patient and show them that you care about their diabetic condition. And when you do that, one of the things you can easily do is monitor their blood sugars that they're taking. And if they're not taking, help them get on track to take it more frequently.
It's sort of that team approach and that wraparound care that enables us to build relationships. In this high-risk clinic, we're seeing patients a lot more often than a regular primary care practice might see them, which is once every 3 months. We may be bringing them back every week. We may be doing phone calls every week to touch base. And so when we build those relationships and have that close contact with those patients, we're really able to identify when they're struggling. And because of all the social determinants of health that we know impact our patients, we're asking questions that might not be otherwise asked